Good morning, everyone. My name is Josh. I am a consultant anaesthetist working at Hammersmith Hospital, part of Imperial College in London. And I am delighted to talk to you all today. Thank you for the invite. Thank you to all the organisers of the symposium. And my topic today is talking about why I think the use of TOE outside of cardiac theatres is a fundamental tool in the high-risk anaesthetist armoury. And allowing people to see the collapse before it happens. So all of the cases I'm going to talk about today are cases that I actually got involved with as a trainee anaesthetist before I completed my specialist training in cardiac anaesthesia. So disclaimer, I am a cardiac anaesthetist, but I do other high-risk anaesthetics. And this talk is to kind of focus on why I think it's such a useful tool and an important tool compared to other monitoring techniques that we have. Why it's not for everyone, what the evidence is behind what I'm talking about today, what the logistics and training programs are available in the UK for those who are interested, where the future lies, and it'll obviously involve lots of pretty pictures and videos. So we'll jump straight into the first case. So this happened just very shortly before I became a consultant. I was working at the major trauma centre. I was in the vascular theatre, and next door there was a code red trauma laparotomy going on for a chap who had been stabbed multiple times in the abdomen, had diaphragmatic breach. Fast scan in the ED showed abdominal fluid and possibly a rim of pericardial fluid, and he was wildly unstable in the ED, so went straight to theatre, bypassing CT for a trauma laparotomy. In theatre, the major hemorrhage protocol was activated, and they were struggling with hemodynamics due to kind of torrential bleeding from the liver and the spleen. Whilst it was obviously clear that the bleeding was the main cause of the hemodynamic instability, the question that lay in the back of the trauma team leader's mind was whether there was an involving tamponade situation because of the breach in the diaphragm and the involving and the rim of pericardial fluid seen in the ED. So they called for me to come and assist with TOE just to lay to rest any concerns about pericardial effusion. So within 5 minutes, I had the machine set up and placed, and I gained these images. And so for those of you not familiar with TOE, this is what we call a mid-esophageal four-chamber view. It's essentially a TTE, but in reverse, upside down. So the left side of the heart is on the right, and the right side of the heart is on the left. And you can see from this image what we have is a rim of pericardial effusion at the bottom of the image, just around the RV and the LV. But otherwise, we have a hyperdynamic tachycardic heart that is contracting well with no obvious chamber collapse. So there's no evidence involving tamponade physiology here. There's just evidence of a hyperdynamic heart which fits with a bleeding patient. So this allowed us to focus our efforts on continuing the blood resuscitation, forget about any surgical need to go into the chest, and an hour after this or so, once the bleeding had stopped and we'd caught up with the blood, the hemodynamics settled. So I think this case highlights quite nicely why the use of TOE can be important for those who do high-risk anaesthesia, and that's because instability is common. And a lot of our monitoring techniques pull values from indirect measurements and makes a lot of assumptions about things and makes making a diagnosis sometimes quite tricky. And there's evidence out there that rescue TOEs do change management more often than not. There's been a couple of studies showing that the anesthesiologists that use TOEs as part of a kind of rescue diagnostic strategy, it changes their management about 50% of the time. So what are we trying to diagnose, or what are we trying to assess with a TOE? So the reliability of diagnosing LV failure, RV failure, and tamponade for TOEs is very good and pretty quick and easy to learn for the kind of novice to intermediate echocardiographer. What it's not very good at is measuring or assessing intravascular volume state, and we'll come on to that in a bit. The joy about TOE versus our kind of other monitoring techniques is that it gives you a kind of conclusive real-time diagnosis by connecting your physiology and your anatomy. And it's very much targeted at the pump. And if it's used in the right cohort, the results are often pretty valuable and lead to change in management strategies. So why is it not very good at measuring intravascular volume status? I think what I want to make clear here is that for the novice/intermediate echocardiographer, I think volume status from a single shot of a TOE or a TTE, the evidence behind it is very poor, and that's because this is a static shot of the chamber size or the LV end diastolic area or the IVC size. And there are so many confounding factors, particularly in the intraoperative state, that affect these variables that making a snap judgment call saying, oh, that ventricle looks empty, they need filling, the evidence behind doing that is actually very poor. And actually, it's one of the things I hear a lot of people who are starting to learn to do echo do. And actually, I think they don't fully understand the concepts behind it or the flaws behind their methodology. So it's not really a tool I use for volume status. It's more a tool I use for assessment of the pump. So it's all about asking the right questions. And the main question you're asking is the pump pumping? And if it is pumping, is there any obstruction to flow? And then, therefore, by getting a real-time kind of diagnosis about the pump, you can then target your therapy, be it fluids, inotropes, or a change in surgical strategy. So this is another transoesophageal echo. This time we're in the stomach, a transgastric view, and we're looking at a short axis picture of the left ventricle. And you can see, whilst it's pumping fairly well, there's a large pericardial effusion around it. So this would be a kind of evolving effusion, probably heading towards a tamponade scenario. So my next case is from when I was the liver transplant fellow. And we were doing a transplant overnight, pretty uneventful course so far, but we were prepping for reperfusion. And for those of you that have done liver transplants, we all know reperfusion is a fairly rocky and hairy time as you release all the kind of waste products from a cold and ischemic liver back into the circulation, straight into the right heart. So TOE was fairly standard practice for all liver transplants at this institution. So at reperfusion, as we expected, the hemodynamics began to wobble. And on the TOE, we had a rapid diagnosis as to why. So again, this is another transoesophageal, mid-esophageal four-chamber view. And on the left-hand side is the right heart. And you can see that it's bigger than the left heart. And rule of thumb, it should always be smaller. And if you look at the contractility, you've got minimal radial function and minimal longitudinal function. So this is a diagnosis of acute RV failure. And the RV dilates and fails very quickly, very acutely, due to its kind of thin-walled nature and inability to change its contractility to changes in afterload. So we could then view that in another image or in another view. So this is what's called an RV inflow-outflow view. So you've got the RV coming through the tricuspid valve, wrapping around the aortic valve in the middle of the screen. And again, this is a dilated RV with no contraction of that RV free wall. So again, this was a diagnosis of acute RV failure and was managed with kind of inotropy, so bolus doses of the calcium and adrenaline to facilitate the RV to manage those kind of waste substances that have all just been released into the pulmonary circulation, increase the pulmonary afterload. And we obviously took care with further fluid loading of that right ventricle. And within a few minutes of giving some adrenaline, that RV had come back down. It was no longer dilated and was contracting nicely. This was another case in a vascular theatre. So a chap who'd had an aortobifemoral bypass. and the operation was essentially at the end. All the anastomosis had been finished. We'd had reperfusion, but suddenly there was progressive and profound hypotension with no clear cause. Surgeons denied any bleeding. There was no bleeding in the surgical field, nothing coming up the suckers. And so my colleague who was doing the case was concerned for perhaps a new cardiac ischemic event or perhaps new cardiac failure. So asked me to assist again with the TOE. So within 5 minutes, we had these images, which showed essentially just a hyperdynamic tachycardic heart again. So it ruled out a left ventricular problem, it ruled out a right ventricular problem, and there was no gross kind of regional wall motion abnormalities, so kind of ruled out a new ischemic event, which we couldn't kind of tell from the ECG because of a pre-existing left bundle branch block on the ECG. So we went back to the surgeons and said, this is not a heart problem. Are you sure there's no bleeding? And actually, after exploration of one of the groins, one of the distal anastomosis had not blown, but was leaking, and the blood was trickling out underneath the drapes that no one could see. So after redoing that anastomosis and resuscitating with blood, again, we had stability. It's finding its way into various parts of the hospital. Obviously, it's already been it's fairly standard for use in the cath lab, but it's becoming more common in the emergency department and the intensive care, particularly for the peri-arrest patient, who you want live kind of diagnostic imaging of the pump in patients who you struggle to get a transthoracic echo on, be it for body habitus reasons, be it for a patient just lying flat on their back with lung pathology. All of these can kind of preclude nice transthoracic images. It's obviously standard of use for in the cath lab for assessing post-STEMI ischemic MR patients or VSD patients, and it can be used for the management of tamponades and the treatment of tamponades. And this is an image that you kind of never want to see. This is a chap who developed one of the worst cases of heparin-induced thrombocytopenia that I've ever seen, and had refractory hypoxia essentially. And once we scanned him, we found this clot that would extend all the way down from his IVC into his pulmonary system. And you can see it here again in this mid-esophageal four-chamber view with these clots bouncing around off his tricuspid valve and in his right ventricle. So this chap was taken for a thrombectomy, an embolectomy, but unfortunately arrested and ended up on ECMO. So he had multiple uses for his TOE, because TOE is also very useful to guide emergency insertion of the ECMO cannula, venous ECMO cannula, into the IVC and SVC when you don't have direct access to fluoroscopy. So this case is slightly more advanced, but I thought it was fairly interesting, so I wanted to include it. This was a case, again, I did as a trainee in the vascular theatre for a chap who had known hypertrophic cardiomyopathy. And you can see in the still of this transoesophageal echo the wildly thick septum and infralateral wall. And then he presented with a mycotic iliac aneurysm, which needed repair, surgically very complex. Blood loss for the whole operation was 10 to 15 litres. And every time he would bleed or we got behind with blood resuscitation, he developed essentially systolic anterior motion of the mitral valve apparatus, in particular the chordae. So if you look carefully at this TOE, if you watch the leaflet closest to the septum, you can see the cords being pulled towards it when the mitral valve is supposed to be closed. So this was causing an LVOT obstruction. And if I pause it at the right point, I'll make it just slightly more clear. So that is when the mitral valve should be shut. There's a coaptation of the leaflets, but you can see the cord being pulled towards the septum there, causing an LVOT obstruction. This was obviously evident through other monitoring techniques, so we could see on the art line that the area under the curve would significantly decrease when he had the LVOT obstruction. But the cause of it was obviously much more evident and easier to spot on a TOE. So we would fill the patient or hit go on the rapid infuser when we saw this to catch up with our filling, and then that would result in an echo that looked like this. So nice, clear left ventricular outflow tract with no movement of that mitral valve apparatus towards the septum. So where is potential future applications of TOE outside of the cardiac theatres? Well, one thing that's getting a lot of attention at the moment is TOE guided CPR. So we know that if your hand position if your hands are in the wrong position on the sternum, you will perform compressions over the LVOT and aorta, which will prevent blood being ejected. And by just moving your hands down the sternum, you can then compress the RV of the heart and allow ejection through the LVOT. And you can see that on echo quite nicely. So this is a video that I've actually just stolen off of Twitter with a credit given below. But if you look on the left-hand side, the compression is right over the aortic valve and the LVOT, and there's no aortic valve opening. Whereas if you look on the right-hand side with slight adjustment of the hands, you can see the LVOT, you can see the aortic valve now opening with each compression. And again, because of if you have a TOE to hand, which I know a lot of places don't, but if you do, you can have this set up in the patient within a few minutes of the arrest. And there's some evidence that the studies haven't been big enough to obviously be powered to assess for mortality benefits for TOE guided CPR, but there is evidence that it does improve your return of spontaneous circulation rates and that it can improve your end tidal CO2 post ROSC. So this is a kind of watch this space topic. So what are the practicalities of training and maintaining a TOE kind of service or a resuscitative TOE service in your hospital? You need to be aware of the safety profile. You need to understand that this is a focused study with clear, direct questions. We're not asking you to make an assessment of whether a valve is moderate plus, or severe. These are clear, easy to answer questions. It does require a reasonable amount of training and obviously implementation of governance to ensure standards are upheld. So what are the risks of TOE? The one that we're mostly concerned about is esophageal perforation, which is rare. So I kind of quote 1 in 1,000 to my elective cardiac patients. I get a bit twitchy of patients with kind of varices, particularly untreated varices, and those with portal hypertension. But again, it's all about a risk-benefit analysis. And then the minor ones are sore throat, a dysphagia, which can be chronic, and a dinophagia and minor trauma to the surrounding structures. All of which probably you're not too bothered about in the kind of situations that we've been talking about. So what is the training? So in the UK, for those who want to stick purely to kind of a focused TOE practice, the Intensive Care Society offers the focused TOE accreditation, and this is essentially an online training module or attending one of the registered courses. It's an exam. It's 50 supervised scans with a supervisor who has accreditation in this or one of the slightly higher, more advanced accreditations, and this generally takes about 1 to 2 years. For those who then go on to either become a cardiac anaesthetist, cardiologist, or just have a general interest in progressing their echocardiography skills, can undertake the full kind of either British Society of Echo or European Association of Cardiovascular Imaging accreditation, which is the one that I've done, which is a lot more intense. So the exam is much, the exam comprises a lot more kind of quantitative assessments of kind of valves and ventricles. and requires a logbook of 125 scans, again over a 2-year process with full reports. So in summary, take-home points: when should I think we'd be using TOE outside of cardiac theatres? Essentially when you've got anyone with unexplained hypotension and there's a kind of disagreement either between you and your monitoring, you and your internal monologue, or you and a colleague, or you and the surgeons not quite sure what's going on. It's generally useful in the higher risk patients, in patients that you have specific pump related questions that will change your management, be it your pharmacological management of the patient or the surgical strategy that you're currently undertaking. And there's a debate whether it should be reserved for rescue use or whether we make it more routine in our higher risk patients. And finally, this is one of my favorite images that I made when I was starting to train in cardiac anaesthesia. This is a chap who presented for a mitral valve repair, who had a mitral valve annuloplasty. We came off bypass, had a bit of instability. It wasn't evident why. Looked at the TOE, and you could see that the annuloplasty ring has dehisced and is partially occluding the inlet to the mitral valve. And you can see that suturing there, half in, half out. And I think that highlights quite nicely that a picture paints 1,000 words. So with that, I will stop there and hope we have some time for questions. Thank you very much.